Hello and welcome. Dr. Sarina Schrager and I are here to talk about shared decision-making in cancer screening. Welcome and thank you for attending our electronic workshop on shared decision-making conversations for cancer screening. You just met Sarina Schrager. I wanted to thank her for being such a wonderful collaborator in this project, as well as I want to acknowledge some other important collaborators, including Tiziana Leal, John Keeble, Mariana Shershneva, and Alice Uroff. And special thanks to our funders for this project, the UW Health Innovation Grant Program. Today we're going to talk about shared decision-making and how cancer screening recommendations and decision-making conversations in the clinic create an opportunity for a shared decision-making conversation. We're going to spend most of our time talking about the conversations and how to construct a shared decision-making conversation, and we'll use either a breast or a lung cancer case to demonstrate. And then we'll practice different techniques for engaging patients in that decision-making process. A reminder that there is the U.S. Preventative Services Task Force, which has a set of guidelines grading different screening tests for your consideration. Today's talk is not about screening tests and gauging the quality of the screening test, so we will just point you to the USPSTF as a consensus place where you can find current grades for the various screening tests. Just a moment on lung cancer screening so that we're all on the same page. This carries a B recommendation from the Preventative Services Task Force, and the CMS requires a shared decision-making conversation in order for it to be covered. This is an exceptional status, and lung cancer screening is the only screening test at the current time that requires a shared decision-making conversation. As a reminder, patients that meet the criteria for lung cancer screening include age greater than 55, 30 or more years of smoking history, either currently smoking or quit within the last 15 years. For breast cancer, there are two different recommendations from the USPSTF, including a Category C recommendation for women under 50 and a Category B recommendation for women over 50, between 50 and 74. There's a recommendation for a shared decision-making conversation, but slightly less than the requirement that we saw for lung cancer. As part of our process for preparing these workshop materials, we surveyed primary care physicians at UW Health. We got 72 responses, and our primary set of questions was about how people feel about shared decision-making conversations, where the barriers are, where their knowledge gaps were, where we could be of the most help. We got 72 responses. We were encouraged to see that roughly 90% of people felt that shared decision-making was a good idea, that it increased the quality of care, and that they were already practicing or trying to practice shared decision-making conversations. We noticed that a small minority, about 1 in 10, are using HealthLink tools consistently to help them in these conversations. And perhaps not a surprise to us, but about 2/3 of providers thought that time was the main barrier to share decision-making conversations with their patients. And so we have more expansive results if you're curious, but that's the highlights. We realized that there are a significant number of barriers to shared decision-making conversations, and we include a few here, which is sometimes nuts and bolts things like, how do I elicit patient values? What are my values that I bring to the table? What other competing priorities and what other competing priorities for our time during this visit are there? What's my previous experience and potential harms? This is a partial list, but some barriers. And then the main barrier that many people bring up, which is about time. Will this slow me down? Where am I going to find the time for this conversation? So let me just briefly say that being more skilled at a task, imagine something that's simpler and more accessible, like your bathroom sink is leaking. When you are really skilled at fixing the bathroom sink, like a plumber, you probably arrive, and with only 1 or 2 trips to the truck to grab some equipment, the faucet is fixed, no more leak. If you're someone like me, you may take 2 or 3 or 4 trips to the hardware store before you have finally given up and called the plumber. Before you finally fix the faucet. So being more skilled at a particular task does not make you slower. In fact, it generally makes you faster. And I would say that actually when a more skilled person is slower, in a conversation, that's because they were very deliberately moving slower, because they appreciated factors at play that made them slow down. So let me say that if we go through this communication training, you may pick up some new skills. You may initially, as you're learning to work with these new skills and you're acquiring those skills, may slow you down slightly, but ultimately being more skilled at this conversation will not slow you down. Another comment that we get from clinicians is sort of represented by this picture here. We oftentimes see patients in a blur. Either we see them because they're very far away as part of a population statistic, or we see them when they're really close to us, for example, as a pathology result or a laboratory test, or we see them zooming past us very quickly as a matter of a busy day with lots of patients to see. Shared decision-making conversations, and I think the reason why clinicians and patients find them valuable, is an opportunity for you to slow down, to bring someone into focus, to spend a few minutes really concentrating on that individual, on your relationship with them, on what's important to them, what they care about, where they're trying to go. And it turns out that those conversations are intimate and valuable, and we derive professional satisfaction, and patients derive satisfaction from those conversations. So when you have an opportunity to do a shared decision-making conversation, it's an opportunity to slow things down and to stop the blur.
Okay, so we ask, what is shared decision-making? And I think it's helpful to go through sort of a history of communication between clinicians and their patients. Looking back, probably the easiest and the quickest method of decision-making we call paternalistic, where the clinician gives information and recommendations to the patient, and then the patient does them. So the clinician will say, it's time for your screening mammogram, and the patient says, okay, and goes and schedules it. Informed medical decision-making adds a little bit to the recommendation and information, where the clinician not only says it's time for your screening mammogram, but says the recommendations say that everybody your age should have a mammogram, or breast cancer is becoming more common, or you haven't had a mammogram before, it's time to do that. So the third, and what we're really talking about today, is shared decision-making, which is predicated on the idea that the clinician comes to the conversation as the content expert, but the patient comes to the conversation as the expert on what's important to them. So the way that this works is the clinician talks to the patient, tells them what the recommendations are, informs them about risks and benefits of the different screening tests, and then elicits information from the patient, really looking at what's important to them. How would they feel if this certain result came back? What would be make it easier for them to complete the screening test? Those conversations continue, and then ultimately the clinician and the patient make the decision together. That is the shared decision. So why should we do shared decision making? I think Toby made a good point in that there is a lot of information suggesting that clinicians get a lot of satisfaction from doing shared decision making. Also, sort of the nuts and bolts of it, we increase patients' knowledge. We actually increase the number of people who have an accurate perception of their own risk, and we increase the number of people who have an accurate perception of what the risks and benefits of each particular test is. There's a good Cochrane review that looked at a lot of different studies and found that when shared decision making was accomplished, patients had less decisional conflict, meaning they made a decision about whether or not to get screened and weren't sorry about it later. Shared decision making also has a positive impact on clinician-patient communication and may improve patient satisfaction. They did look in this Cochrane review at time, and having a shared decision-making conversation really had a variable impact on time. And the median increase in time was 2.5 minutes. If you think about it, telling somebody what to do doesn't take very much time at all, but actually having a conversation with them will inherently increase the amount of time that you use. As you get more and more skilled at doing shared decision making, hopefully the amount of time that is needed is not significantly high. Part of the what makes shared decision making really effective is using decision aids. And what decision aids are is they're either electronic or paper visual representations of risk. So people can look at these decision aids and sort of see, looking at the picture, what could possibly happen to them. Decision aids actually work really well when you're looking at the information that people get and the different options. And it really gives people an accurate description of harms and benefits of different tests. Okay, so there are a lot of different models of how to do shared decision making. We have chosen to use a relatively simple one because it's easier for us to understand. The simple model that we are using is derived from a paper by Glenn Elwyn, who is a researcher at Dartmouth. And what we are calling it is COD, as in the fish. It's easy to remember, and we're going to walk you through it. So COD stands for choice talk, options talk, and decision talk. We want to make sure that people know that this is not necessarily a linear discussion, that you mention a choice, but then the conversation about options and decision can actually be more of a circular conversation. It's not a lecture where you're not starting at one place and ending at the other place. You're starting and then you're sort of following the conversation and the feedback you get from patients to decide where you end up. So, choice talk. We feel it's really important to label that the patients have a choice. There is nothing that comes out of that. Sorry, I'm going to say that again. We feel like it's really important to label that the patients have a choice. It is their choice whether to get a screening test or not. But we also think it's important that the clinician tells them, you're ultimately making the choice, but I'm there with you. I'm going to help you make this choice, and we're going to actually get to the end together. We think it's important to actually include that word, choice. Getting screened for breast or lung cancer is your choice. You have a choice about getting screened. We actually have a few other examples here, and you can feel free to practice them. See if something sounds right for you. Options talk. In this option talk, you're actually giving the pros and cons, risks and benefits of different screening tests. And it's really helpful to use a patient decision aid and to check understanding that and make sure that the patient understands what you're talking about. Key components of options talk are looking at a person's individual risk. We have some good risk calculators that will give people a sense of what their risk is. People don't necessarily need a number, but in an assessment of whether they're at average risk or high risk or low risk, sometimes will help moving forward with the conversation about whether or not to get screened. We want to make sure to talk about benefits of screening. Most screening tests that are recommended have a benefit of saving lives. The controversy comes in when you look at the number of lives saved and balance it with the potential harms and negative side effects. When we look at harms of screening, we have two different categories that we're talking about. One are false positives. So screening tests that come back as positive or questionable, and then people need further tests. Often just extra radiologic tests, but sometimes actually invasive biopsies. Second harm of screening is overdiagnosis, and overdiagnosis is actually really complicated, and it's really hard to explain to people. I think data shows that many clinicians don't even understand what overdiagnosis is. In a nutshell, overdiagnosis means that if we're thinking about a large population, that there are people who have cancer that would never become clinically apparent. Perhaps their body takes care of it, or the cancer is really slow growing, or they get sick from something else. But the idea of overdiagnosis means that by screening or going looking for cancers, we're going to find cancers that never would have caused any clinical effect. Okay, so options talk when we're thinking about how to do that. We've told the patient they have a choice of whether or not to get screened. And the next step is to really be explicit about saying, I want to talk to you about the different options. Is that okay with you? I'm going to use this online decision aid to describe the different options to you. We'll talk about the benefits and harms of screening. I think it's really important too to continually ask patients what their thoughts are, because at that point, that's where you're getting sort of the circular conversation about getting a sense of what's important to them, getting a sense of how they're going to go about making their decision. Okay, and then the last part would be the decision talk. Elicit patient preferences, arrange the next steps. Examples. Now that we've talked about the potential harms and benefits of screening, tell me your thoughts. Are you ready to make a decision about screening? You don't need to make a decision today. You can take home this information and think about. So what would help you make a decision? Some examples.
So if you think about the kinds of mindsets that a patient can bring to a shared decision-making conversation, there really are sort of three. Some people have a fixed opinion. They've decided, I want to do screening, or they have a fixed opinion, I don't want to do screening. And then there are people who have some degrees of neutrality. They are perhaps of the opinion that they'd like your recommendation, or perhaps that they really would like you to give them more information so that they can make their own decision, but they are in some ways neutral. So we've made a series of videos demonstrating how you might approach a conversation with people in these different mindsets. Some people who've made up their minds, some people who are asking for your opinion, and some people who really are open to and would prefer a discussion. And these videos then extend to places where we are demonstrating the part of the conversation where we're talking and exploring the options, where you're eliciting values, hearing those values, and ultimately making a decision and in the form of a recommendation from the physician. So the choices and options and decision talk that Sarina just went through, we are demonstrating in a series of videos. You may choose to watch some or all of these videos now. Welcome back. You've had a chance to watch as many videos as you would like to watch. One of the things that I would point out is that these videos obviously were written. We designed them, and so they flow, and we knew how they were going to unfold because they were designed. And in real life, these are conversations. They aren't lectures or speeches. And so you should be prepared to engage with the patient and respond with whatever they're bringing forward, whether it's a concern, whether it's a request for a recommendation. I think once you have a sense that we want to name that they have choices and explore what their two options are, elicit their values and goals, and then ultimately come to a decision and make a recommendation, I think you'll be able to engage with them in a conversational way that ultimately reaches a decision that you both are comfortable with. Embedded within your UW Health HealthLink EPIC program are a number of tools. One of them to help facilitate shared decision-making conversations is a set of tools called HealthDecisions, healthdecision.org. And they help you by pulling in some information that exists in the patient chart, partnering that with some information that you will input, and ultimately giving you a chart. Now, each shared decision that you go through results in a different chart, of course. The example that we're showing you here is a patient that is at risk for lung cancer and for which you've used the HealthDecisions tool for lung cancer screening. And so this is just an example that shows you the kind of information that you can extract using a HealthDecision tool within HealthLink to help you navigate this conversation. In particular, it can help you populate the baseline risk for this particular patient, the risk for a false positive test and additional testing. These sorts of things are mapped out for the different decisions.
As an example of extra supportive materials, we've developed a breast cancer screening shared decision-making toolkit, and it's available at this website. This toolkit actually contains information for both clinicians and patients and goes into more depth about different shared decision-making conversations, specific language to use, patient information, and is very helpful and is free and available to everyone. We have also information about small group role plays that, if you are interested, are also available at this particular website. Feel free to go through and use them and practice using some of the conversation and some of the language that we've talked about today. More information can be found at this website. So thank you on behalf of Dr. Toby Campbell and myself and the rest of our team for spending your time watching this presentation on shared decision-making and cancer screening. We hope you've learned and are inspired to continue our patient-centered, evidence-based conversations with your patients about cancer screening.